I'm going to give you a little primer on inflammation. I'm going to start with the mechanistic information about inflammation, and then there'll be a second lecture posted about the clinical tie-ins. So here we go. This is chapter 2. The learning objectives for this chapter will be to, first off, describe the inflammatory response. This is something that you probably learned in anatomy and physiology. If you took micro, this is something you also went over there. So hopefully it's a little bit of review, and we'll review the vascular changes, the cellular events, and the chemical mediators that help make the inflammatory process work. So I'm going to go over the specifics about each of those things, and then I'm going to put them together for you. And if you can tell it kind of like a really kind of boring bedtime story, then you're going to be just fine. Then we'll get into the clinical presentations. We'll talk about exudate. And before we get there, I will tell you right now that exudate is defined as fluid that's formed via inflammation. So that's all it is, fluid formed via inflammation. And exudate can either be serous, purulent, fibrinous, or hemorrhagic. And you'll see that each of those has a very different presentation and involves the extent of mediator release and then vascular response. Because I'm a pharmacologist, I will also talk about how non-steroidal anti-inflammatory drugs interact with this process and in some cases interfere or stop it altogether. And then I want you to be able to describe what the differences between acute or very short-lasting flares of inflammation versus chronic inflammation that you see in chronic inflammatory disorders. And they're pretty straightforward, I think. So going forward, we'll go through the 5 cardinal signs of inflammation. And as you see in this picture, this person here has a little hangnail that has become inflamed. So you see some redness and swelling, and we can see that the finger is very swollen because that shininess there, that's letting you know that the skin is being stretched and it takes on this different appearance of being shiny. We can also see some fluid forming at the nail bed there. And in this case, that's an exudate. It's not serous or clear exudate. This is what people would call pus. And pus is purulent exudate. It's generally yellow or green, and it's tinged in color by the native bacteria in that area. So this is whenever you see purulent exudate, that tells you that there is an infection with some sort of bacteria. So the 5 cardinal signs are swelling, which we see this finger is swollen. Redness, we definitely see the redness. Heat, you cannot see the heat, but if you have ever had an injury like this, when you touch it, it feels hot. And the reason for that is there's increased blood flow to the area, which we call hyperemia. Hyperemia meaning excessive blood flow. And remember, blood's almost 100 degrees Fahrenheit, so about 98.6. So this is going to feel warm. It might be pulsating, and it is going to have quite a bit of pain for that individual. And the final cardinal sign is loss of function, meaning that it's going to be difficult for this tissue to do what it normally does. And then it makes it more difficult for you to utilize, in this case, the digit for its intended consequence. So it might be more difficult to write. It would be very uncomfortable to put this finger into a bowling ball or a glove or things of that nature. So that's important. When we keep things away from use, we're essentially keeping them from further damage. So we'll take a look at some more clinical pictures from my textbook. Here we have acute inflammation of the ear, and this is something that you'll see in a variety of when you're allergic to something, an allergic reaction. This can happen in response to like a chemical. So let's say somebody used a new detergent that they have an allergy to. The ears will swell up like this. Sometimes when somebody ingests something that they're allergic to, the ears will swell up like this. Fun fact about my oldest son, he's allergic to red dye. And the reason I know that, not only does he get a contact rash from anywhere red dye touches, his ears swell up really big like this. So I can tell if he's been eating something he's not supposed to. So we still see the redness, the swelling. We see the shiny skin telling you that the skin is being stretched. It would be hot. And the ear, in this case, its job, this is the pinna, its job is to collect sound waves and then route them into the inner ear. And we see that the shape is distorted, so it's not going to have its normal function. In the next picture, we see a very pronounced type of inflammation. So this is a burn, and if we popped one of these pustules, or cysts, which you should never do, that causes more damage, what you'll see is this fluid is clear. And clear fluid, see it's a little bit yellowish there, that's a normal color of serous exudate. So that's what you see in mild inflammation, especially in burns. In this case, on the buttocks, if you own a home or have ever touched a hot water tank is something on it called a rider, and you can set the rider so that there's a max temperature that the water can be heated up to. So when you have kids, when you are giving a kid a bath, it's really important to test the water before you allow them to go in or place them into the bathtub, because depending on how high the rider is set, the water can get really hot. So unfortunately, that's what happened to this individual, is they were placed into the bathtub, buttocks first, and it turned out the water was scalding. So that's a pretty extensive burn. So extensive burn with serous exudate, and when the fluid leaves the vessels, which is where we hold most of our fluid in the vessels as plasma, when it leaves, we call that extravasation. So this is fluid extravation forming this serous exudate, which is going to serve as a way to dilute any pathogens that might be in that area, but also kind of coat the damaged tissue. So if you think about being in a burn ward, individuals have cold, wet, packed bandages laid on them to allow the tissue to heal, but also prevent dehydration, because if the skin is not there, it's easier to lose the water to just the air. So having this fluid in there allows the tissue to heal normally and remain hydrated. So it's important never to pop things like this. That does cause more damage than letting them heal on their own. And again, with loss of function, your buttocks are there to do things like sit upon. You can imagine that it's going to be quite a bit of time before this individual can exercise their normal function. So in inflammation, we have a variety of things that trigger this response, and then we have mediators that help the response be amplified. So inflammation can happen because of a chemical agent, like we mentioned with an allergy. It could be something touching the skin, touching the body. It could be a burn, something of that nature, like a chemical burn. There's physical agents, so that could be any of the trauma-based mediators of cellular injury we talked about in class, or it could be a pathogenic microorganism like in the finger that is swollen. In most cases, staphylococcus is what you'll see on the skin and on surrounding surfaces. So all of those things can cause injury to the tissue. And then we get the inflammatory response. And the mediators, these things that are released, they're going to help, again, amplify this response. So we're going to go through these different mediating processes. So the first thing we'll talk about is what the vascular system does. This is mainly at the site of the capillaries, so the very small vessels located in the tissue beds. They're going to respond by allowing increased blood flow to the area for a variety of reasons. And when those capillaries become engorged with blood, they're going to stretch the walls of the capillary. And we'll take a look at a picture of that. Capillaries are one cell thick, and there's not anything really separating those besides a little bit of connective tissue. So when these capillary walls get stretched, it's going to make it easier for fluid to leave the capillaries. So we talked about that extravasation of fluid. Attraction of leukocytes. Leuko means white, and cyte means cell. So traction of white blood cells, essentially. White blood cells travel in the vessels, like the capillaries. So in order for them to leave the vessel and then go to the site of injury to remove any pathogens or cellular debris, they're going to have to migrate out of the bloodstream. And then systemically, the body is going to respond to inflammation. We'll see that fever is an important process here. Fever is when your body essentially changes the set temperature. So we said about 98.6 or 37 degrees centigrade is normal body temperature. And when you get too hot or too cold, your body engages in a process to bring you back to your set temperature, back to your homeostasis. In fever, the body physically changes the set temperature at the level of the hypothalamus. So instead of you running at 98.6 and your body fighting to get there, in fever, your body sets it to 100, 103, 105, and everything the body does will be to maintain you in that higher temperature. And the reason for that is we are very bad at making new bacteria or new pathogens when the temperature is high. So bacteria are less likely to replicate. And also the white blood cells and other immune cells, they work more efficiently at high temperatures. So having a fever, even though it feels really terrible, and we usually take Tylenol for it, it's a really important process in this inflammatory cascade so that we can allow bacteria to stop replicating and our own cells to work more efficiently. And we'll also see an increase in white blood cells. That's called leuco, so white. We know cyto is cell, and osis means development of. So the development of white blood cells, leukocytosis, will have increased white blood cells circulating in the system. So whenever you take a blood sample from a patient and you see increased white blood cells, you know that they're sick. You know that they're fighting some sort of infection. So these vascular changes and cellular changes, systemic changes, those are all going to lend themselves to those 5 cardinal signs of heat, redness, tenderness, or loss of function, swelling, and pain. So we call this the acute inflammatory response. And if you click on this link, you'll see a video, but I will post that on the Canvas site for you. And it's going to go through all of the different steps of inflammation. It's also got some pretty amazing music that starts it out, so I highly encourage you to watch that. But acute inflammation is anything like a paper cut. In this case, the person has a splinter, something entering the skin. And when we have this noxious event, so something that damages the host, the person, and creates a wound, we have this cascade of inflammation. And inflammation is part of the body's innate immune system. So this is something that occurs to try to avoid an immune response, which we'll see in the next chapter is very debilitating to the body. It utilizes a lot of energy, and we try to avoid them at all costs. So we would consider inflammation part of the innate or kind of built-in immune system along with cilia, mucus, those other things. So if everything goes correctly in the inflammatory cascade, we're removing the injury-causing agent and limiting the extent of tissue damage. So if we take a look at this picture, we've got a splinter coming in and we have a wound, and chances are the splinter is not pristine. It probably didn't just come out of a surgical pack. It's probably from the ground. It's probably dirty, which means coming with it, we're going to have a whole host of different bacteria, pathogens, and then also these cells are now dead that were damaged by the splinter. So we'll have cellular debris released from these dead skin cells. So step 1 is the damaged tissue, they release histamines. So we'll talk about that. Histamine is a mediating factor, and it's the most important mediating factor because if there is no histamine, the rest of the cascade can't occur. So histamine is going to affect the blood vessels, so the capillaries become more leaky, and once the capillaries become more leaky, we see the white blood cells being able to leave through those leaky spaces. So histamine interacts with endothelial cells so that we make these spaces wider. So we have phagocytes, so these cells that actively eat. So here we see a phagocytic cell ingesting a pathogen. Remember, it'll take that into itself and then merge the vesicle it's in with the lysosome to digest it. And then it will extract or kind of poop out or excrete any leftover products that shouldn't accumulate in the acute inflammatory response. This is also when we start to form a clot, because if we don't clot this wound, then the blood will come out and won't stop. So we have to form a plug for clotting. Step 3 is phagocytosis and destruction. So these active white blood cells will ingest and then process and excrete the pathogens. And then finally, we have platelet sealing that will seal this area of the capillaries so that we don't have further things leaking out. Platelet sealing is something we see constantly. If you have adequate platelets, you don't really see any signs of it. When you do see low platelets, you'll see that people develop something called petasia, which looks like a little pinpoint red or pink rash. And that could be on an organ or on the skin, but that tells you that there's not enough platelets to seal up the capillaries. So you get little microbleeds. So now we're going to move through the inflammatory response. We'll go through the vascular phase and then the cellular phase. And again, all of these are active links, so feel free to click on them. Okay, so we'll start with the vascular system. So the blood vessels have to, again, remember, the whole point is that these white blood cells need to leave. So all of these things are happening just to let these white blood cells out so they can traffic the area. So the vascular changes are occurring mainly to let that occur. So the microcirculation refers to the really, really small capillaries in the system. Capillaries, this is a nice video which shows blood flowing through a capillary. And let's see if I can click on that while we're recording. So there we go. Everything is working. So when you take a look at blood flowing through capillaries, so here we have an arteriole, we have a venule, and those things are connected by this meta-arteriole. So I want you to notice how the red blood cells here, they're flowing in single file through the capillaries. So when I say microcirculation, I truly mean microcirculation. It's this small, just a couple of micrometers thick. This is in a mouse, so you might see the screen going up and down a little bit. That's with the respiratory movements of the mouse. So when I say, grade 9, good job, bros, microcirculation, I truly mean microcirculation. Okay, how do I get out of this screen now all right, there we go. So capillaries are very small. Go away, Duville. It's like Big Brother up in here. All right. They are going to convey blood to venules, because remember, veins drain tissues. So here we have an arteriole, which literally means small artery. So the smallest part of the arteriole, highly oxygenated blood coming from the heart. And arterioles are connected to venules, which will drain the used blood, the deoxygenated blood, and bring it back up to the heart and lungs to be reoxygenated. What connects those are capillary beds. And in this picture, we see these capillary beds. They're all engorged with blood like we would see in inflammation. So taking a look here, a meta-arteriole, remember meta means change. So one change in the arteriole is these little thoroughfare channels. We also call thoroughfare channels a true capillary, because if you follow this through, you can see this meta-arteriole, there's no stop points in it. So even when we can cut off blood flow to other things, this remains open. So if we look here, those little white things, those are pre-capillary sphincters. So that literally means before the capillary bed. So when we want to limit blood flow through a capillary bed, pre-capillary sphincters contract, and they can shut off blood flow through these capillary beds. And that's what you see when you get really cold and you go outside and you know you lose a lot of heat through your skin. So your body doesn't want to lose that heat, it wants to retain it. And what it does is shunt blood flow to the organs and places that it needs to run all the time. So when you get cold, what you'll see is that initially your skin turns very pale because these precapillary sphincters, they constrict. And so the only blood flowing is going to be through the meta-arterioles, or the true capillaries. When you're really hot, we lose heat through our skin. So that's one of your body's heat loss mechanisms. So when you're really warm, you'll see that you become flushed, or if you're nervous, you become flushed, or an inflammation. And that's because these precapillary sphincters, they dilate. And when they dilate or loosen, that means that not only are we going to have blood flowing through there, but it's going to be an increased amount of blood. So when you're warm or stressed, you become flushed. As I mentioned, when you're really cold, your skin at first turns really pale. That's called blanching. And then if you look, like I took my kids sledding the other day, so you get really pale and then you're outside for a while and your cheeks start to turn rosy, your nose turns rosy. That's called blushing. And what that is a signal of is if we have these precapillary sphincters constricted or closed for too long, like think about your cheeks. If these capillary beds are in your cheeks, the skin in your cheeks will start to become ischemic or starved of oxygen and blood. So those cells are going to send out signals like, hey, I'm ischemic, I'm making lactic acid. Your cheeks hurt, right? Like it hurts to be outside when it's that cold. So that signals these to loosen, and then your cheeks will turn red. So that's called blanching slash blushing. Fun, right? It's all physiology. So in inflammation, what you see is when things like histamine are released, when there is cellular damage, we have a dilation of the precapillary sphincters, which are normally regulating blood flow. So it's taking advantage of our natural regulators here. So they dilate, and then the capillary beds will passively fill with blood. So that's the first important thing that they do, is dilation of precapillary sphincters in inflammation. And that's going to lead to the hyperemia, the excessive blood flow, which will make the area appear red, and it'll also make it warm. When we look at a capillary, so here is a micrograph image of an actual capillary cell or capillary bed, just one capillary. And remember, they're very small. Red blood cells flow through in single file. And right here, we see the endothelial cells that make up capillaries. And this picture is stained so that the capillary endothelial cells appear green, their nuclear materials in the middle in red. And then these yellow areas, those are the spaces in between capillaries. So remember, capillaries are leaky. Those cells aren't bound really tightly together, at least in the periphery. They are in the brain, but your brain is special and different, like every one of you. But when we have these precapillary sphincters dilate and blood flow increase, these spaces, so these yellow spaces, are going to become wider. So we have passive increase of blood flow, which will lead to the passive widening of these spaces. Another thing that's important that you see here in red, so not only is there nuclear material in the middle, but there's also actin and myosin. So what does actin and myosin do? It contracts. So we have more blood flow coming in, stretching these capillaries and widening these spaces that we call the endothelial junctions. You also have a message to these endothelial cells to contract from histamine. So the more they contract, the wider these spaces get again. So we have dilation of the precapillary sphincters, increase of blood flow to the capillary beds, and then contraction of the endothelial cells, all working together to make these endothelial junctions wider, to make capillaries more leaky. The whole point of this is to allow white blood cells to be able to leave the blood vessels so they can go to the area of injury. But in doing so, we're also going to have fluid, which makes up 55% of what's flowing in your vessels. 55% is plasma. And that plasma is going to leave in the form of fluid when we do open these gates. So what you see in the vascular response, again, upon injury, increased blood flow, dilation of the precapillary sphincters, that's going to reduce the resistance. So just going through this word very quickly, when you resist something, you don't want it to happen. So vessels, when they're resistant, that means that they're contracted. They have high resistance. It's hard to get blood flow through them. When those precapillary sphincters dilate and we have blood coming in, like in this picture, we have tons of blood flow engorged in this capillary bed, there's now reduced resistance because the dilation of the precapillary sphincters makes that space that blood flows through much wider. So resistance of the vessels to flow is going to go down. So we'll see the passive filling of capillary beds with blood. So hyperemia will occur in these cases, again, so that we can get these white blood cells, these specialized neutrophils out to get to the site of injury. But that increased blood flow will lead to redness, swelling, and warmth of the inflamed tissue. All right, moving on. As I mentioned, we look at an arterial, capillary bed, and then a venule. And where these lines are, we'd see some sphincters. So when these sphincters loosen and dilate, this dilation and this expansion and stretching of the capillaries is really just passive. It's like opening up your belt or loosening your belt on like Thanksgiving or some other holiday where you want to eat a ton of food. It doesn't have to be a holiday. It could just be like Chicken Nugget Thursday. So you loosen your belt so you allow your stomach to passively expand so you can fit more chicken nuggets in there. That's what happens when you dilate these sphincters. We dilate the sphincters, and that allows the passive filling, passive engorgement of these capillary beds. That also means that the pressure in these vessels is going to go up. So back to your food example, you loosen your belt, and now you've got your, let's pretend you're wearing jeans. If you keep eating and your jeans are buttoned, the pressure of your stomach on those jeans is going to go way up. So the pressure in your vessels works the same way. I like to call it like the skinny jeans mechanism of blood flow. There's only so much that can fit in these, so the pressure is going to go up pretty high. And when the pressure goes up, that's going to make it more likely that fluid leaves. Also, when we have dilation and engorgement of blood in a tissue, the blood flow is going to slow down. And the term for that is congestion. In the same way we would say that traffic becomes congested when there's a lane closed or something blocking a street, traffic is congested. So our blood flow becomes congested when we have engorgement in tissues that are, like, remember, capillaries, they're one cell thick. There's no muscle there really to contract and make the blood velocity go up. It's just going to slow down. So the blood becomes thick because it's losing fluid, and it just kind of stays in one place temporarily. You can't live like that, obviously, but it becomes very thick or viscous and temporarily static. The formation then occurs of exudate or transudate. As I mentioned, exudate, if you forget these, you can click on these links and it'll take you to the site that defines them for you. But exudate is just the fluid formed in response to inflammation. Trans means across. So transudate means it's exudate. It's still fluid that's formed via inflammation, but it's gone across a barrier, or it's gone through a barrier. So an example of this, we'll talk about pericarditis in more detail in the cardiac chapter, but pericarditis is the inflammation of the pericardium, which is the protective surrounding around the heart. So let's say that the heart has an infection. You can have tons of infections in the heart. It could be like a valve infection. It could be a strep infection. Untreated strep throat causes a lot of heart issues. that we'll talk about later. I don't want to get bogged down in it. But if you're inside the heart and you have inflammation there, the fluid's going to have to be pushed through the first layer of the pericardium, and then it fills up the pericardial sac. Because it's been pushed through that serous layer, we would call that transudate. It's been across a membrane. So if you're squeezing something across a membrane, it means it's going to be very clear because all the junk is going to be filtered out. So in this picture, this is pretty gross. There's lots of gross pictures in this class. We can see a little caseating necrosis there. Yeah. So we see all the signs of inflammation: redness, swelling. We see the shininess, the tight tissue. And we also see this yellowish, this fluid. So in this case, this is exudate. So exudate, again, just fluid formed via inflammation. And in a place like this, it's just leaving the capillaries and coming out to the tissue. So if we sampled this, we'd see a lot of, it would be like yellow. Transudate is clear. It's been pushed through like a sieve, essentially, because it's gone through a barrier. It's gone through some sort of serous membrane. And it's important that we have exudate. Even if you think about a blister or something, it's there to dilute the toxins so they aren't in high concentration, to go down their concentration gradient to make it into your bloodstream. It helps in the removal of debris because our phagocytic cells can travel in fluid. When people say pus, just remember, exudate is not pus. Exudate is yellowish or clear in the case of transudate. When it is green or thick or yellow or all of those things together, that's called purulent exudate. That's what people call pus. So that has to be thick and it has to be colored. If it's just clear, that's serous exudate. Okay, so purulent, we say a suppurative tissue, or the tissue started to suppurate, like in this case. That means it's starting to form pus. That means that there's an infection. It's not just inflammation, it's infection. Okay, so hopefully that makes sense. Cool? All right. So now we're on to the cellular mechanism. So we have to talk about what the cells are doing in this case. And remember that the main point of all of this is the white blood cells making their way out of the circulation so that they can get to the area of injury. So these guys here, right in the middle, they're called the PMN, which is a long name for poly, which means many, morpho, which means looks like, or shape, nuclear, so nucleus, leukocytes. So they're many formed nuclei, white blood cells, white cell. So if we look at them, this one is a pretty standard polymorphonuclear leukocyte. It's a granulated one because when we stain it, it looks like there's little, I don't know, like dots on it. That means that it contains stuff. These PMNs, it's their job. They're specialized white blood cells. They're the ones that get to that area, and they're designed to respond to injury. They're attracted to areas of injury by the things that are released by injured tissue. So they're a type of granulocyte. Again, granulo means that it's granulated, which means it contains granules, which could be anything in the case of cells. So granules are just little spots, and it means that there's things in there that contain something. They're actively phagocytic, which means they eat things. They get to that area so that they can remove debris. Then they are attracted to that area of injury, which we'll see a nice video of in a second, so that they can destroy and eat or ingest and then destroy the pathogen at the area causing the destruction. Later on, mononuclear cells, so one nucleus, normal white blood cells, they show up later and they help clean up the debris that's left over. So the first people or cells that come to the scene, they're these PMN, specialized white blood cells. They typically have 5 or less nuclei. If they have more than 5 nuclei, they're abnormal, and we'll talk about that in the blood chapter. So we've got these specialized white blood cells. They need to make their way out of the circulation. Okay, so how do they do that? In typical blood flow, when the heart is working properly and pressure is normal, blood flows pretty quickly. We have about there's more than that. Let's just say 6 liters of blood. Let's just say that for now. And the pressure looks good. Blood cells flow at the center of the vessel. And that's important because the closer they are to the edge, the more likely they are to damage those cell walls, which are really easily damaged inside of vessels. That's called shear stress. Shear, like you would shear a sheep. The force of blood flowing through vessels is called the shear. Why is it called that? I don't know. That's what it's called. So axial flow ensures that these components of the blood aren't going to be near the wall. The plasma is carrying them, so they're not going to injure the vessel, hopefully. When there is injury, it's kind of like, so remember, everything is dilating, and blood flow is going to slow down. So we'll see in some other pictures that when there's damaged cells, they release cellular messengers called cytokines. And those are going to start to encourage these cell walls to express receptors on them that were previously just packaged in the Golgi and hanging out waiting for use. So when these receptors are expressed, they attract these specialized white blood cells. And the white blood cells are going to start to migrate towards the wall. So we call that margination. So instead of being at the center of the vessel, they move to the margins of the vessel. So margination is the way that we describe the slowing down of blood, but specifically when the white blood cells start to be attracted to their receptor sites that are expressed by the wall in injury. So in this picture, we see at the final steps, when the white blood cells make it there, they have to squish themselves against the wall so that they're not removed or stripped away by the shear. And they'll find a place where they can leave in that process. So if we want to put together the story, again, it all begins with histamine, but we haven't put together the cytokines yet. But when there's injury, the blood flow is going to slow down because of passive dilation of those precapillary sphincters. The white blood cells and all the elements of the blood will go from axial flow at the center of the vessel to margination. So the blood will slow down, and then the white blood cells will start to migrate to the margins of the blood flow or the blood vessel so that they can now leave. So axial flow, then margination. Okay, once they've moved to the margins, the white blood cells do something called tethering and then rolling. So remember I said when there's injury, the wall will express these proteins. And we see them in this picture. They're called selectin proteins. So these guys were just hanging out in the Golgi, and now they're popping out of the membrane. And also remember that everything in the body is shape-based. The closer they are in shape, the more likely they are to be attracted to one another. So here's our white blood cell. When there's injury, not only does the wall express receptors, but the white blood cells will express receptors too, and they change their cell shape, something we call activation. So they both express these proteins, these selectin proteins, which are attracted to one another because their shapes match pretty well. But here's the deal. They match pretty well enough to bind. However, the blood flow velocity is still pretty quick. When I mentioned that you've got all these liters of blood, that blood circulates through your body about once a minute. So it's going really quickly. So these things can bind to each other, but the shear, the force of the blood flow kind of forces them to bind, and then it's broken really quickly. So then the cell rolls, boop, so that it can bind to the next one. And then the blood will continually roll it so that eventually it has to find a spot to land when blood slows down. But it'll bind and then it'll be rolled down the capillary wall. So you can picture this if the cell was like a person in a wind tunnel and your whole class is standing along the wall. And I turned on the big wind generator fan and you're like, oh man, that wind sucks, I need to get out of here. So you grab on to the hand of one of your classmates, but the wind's really strong and you get blown, and then you grab onto another one, and then you grab another one, another one. So it's just something that can be broken really easily. So it's because this is not a really strong affinity, it's not a perfect shape match, that this bond between the receptors, these selectin proteins, can be broken really easily. So they bind their selectin proteins together, but the blood flow forces them to physically like roll along the cell wall until they can do the next step. So margination, moving to the vessel walls, tethering, which is binding to their selectin proteins, and then rolling, which is a forced process by the force of the blood flow. Okay, so now we're going to follow this. So here's a neutrophil. It engaged in margination. It's starting to move towards the wall here in margination, and then it binds to its protein and it rolls along the wall, and then it changes its shape. See how weird this looks? Whenever a cell changes its shape and grows little selfie, we call that activation. It's been activated. It can now do things and move. So the cell is activated and then it adheres. And that's a pretty straightforward term. We call that adhesion. So it margination, tethering, rolling, activation, and adhesion. Adhesion means that you stick to the wall, like, all right, I'm finally going to make it out of here. And they they kind of pancake themselves down to get out of the shear. And then when they find a nice big space to leave, they will squish themselves through the cell wall, the capillary wall, without disturbing themselves. So they don't become damaged. They can squish through like little gross slugs so they can go get to that area of injury. So after tethering and rolling, the cells leave, and we call that migration. They migrate, and you can see that in this picture. An older term for that is still used on boards, so I want you to know it, is diapedesis. So they're leaving the vessels. The white blood cells are leaving. So I'll use the term migration, but you'll also see the term diapedesis used in other textbooks because it's the old school term for the white blood cells leaving. So margination, tethering, rolling, activation, adhesion, and then migration. The white blood cell is now leaving so that it can go to the site of injury. And the way that it's attracted to the site of injury is called chemotaxis. Chemo means chemical, and taxi means to move. So in the same way a taxi or an Uber moves you from one place to another, we'll use the term taxis or tactic to respond or to describe movement. So chemotaxis is movement in response to a chemical. So here again we see rolling. So they've tethered, they're rolling with their selectin proteins, then they shed their selectin, they don't need it anymore, so they adhere, they're activated, and in this picture it calls it diapedesis. They're migrating through the wall so they can go to the area of injury and destroy whatever the pathogen is. Okay, so hopefully this video works and I can show you chemotaxis. Let's see. Here we go.
These human neutrophils, taken from the blood of a graduate student, are mobile cells that will quickly migrate to sites of injury to help fight infection. They are attracted there by chemical signals that are released by other cells of the immune system or by invading microbes. In this experiment, tiny amounts of chemoattractant are released from a micropipette. When neutrophils sense these compounds, they polarize and move towards the source. When the source of the chemoattractant is moved, the neutrophil immediately sends out a new protrusion, and its cell body reorients towards the new location.
Look, they're just teasing them. So that's what those white blood cells look like. They change their cell shape when they're activated, and then they can move around. These are some really great videos that I want to watch now, like Game of Thrones, more Game of Thrones, Freddie Mercury, the woman whose bedding has not been washed for over 100 years. That sounds really great, but we're not going to do that right now. Let's keep our eyes on the prize and forget about that and move on. So we have margination, tethering, rolling, adhesion and activation, diapedesis, chemotaxis, moving to the site of injury, and then finally phagocytosis and destruction. This is a real PMN. Isn't that fun looking? So this is one that's been activated. So it is a weird shape and it can move actively to the site of injury to ingest pathogens. Isn't this great? Here's some Neisseria gonorrhea. Great! So the body will engage in phagocytic activity to try to ingest and destroy the gonorrhea before it causes an immune response and illness in the host. Remember, when a pathogen comes in, it will be encased in a vesicle and then merge with the lysosome so that it can be excreted. And when it is in a vesicle, we call it a phagosome. I like this because it is spelled incorrectly, and I thought it was funny. Lysosome is a real thing, and it's a non-specific bacterial enzyme that's released by your skin to help kill pathogens non-specifically. It's also in high concentration in breast milk, so that breast milk can be squirted on things and make it less likely for an infection, or ingested by an infant, and they're less likely to get sick. So, putting that all together, margination, the selectin proteins are expressed, so the selectins govern the tethering, the rolling, then that cell changes its shape, so it's activated, and it's adhering now. It's firm adhesion. It squats down to get out of the shear so that it can physically leave through what we call either margination, diapedesis, or migration. And then it gets to the site of injury by chemotaxis. It responds, like in that video, to chemical messages that are released in the bloodstream. So it's attracted to that. So we'll get into these in just a second. The integrins and then the chemokines. Chemo is chemical, and kines are part of the kinin cascade that we'll talk about in just 1 second. So we went through the vascular phase. We have dilation of precapillary sphincters, passive flow or passive filling of the capillary beds with blood. They become more leaky. The actin and myosin in the endothelial cells contract, so we get big spaces and exudate forms. And then we have the cellular phase, which is letting the white blood cells out so that they can marginate, tether, roll, activate, adhere, migrate, use chemotaxis to get to the site of injury so that they can phagocytize and destroy pathogens before they make you sick. Woo, that's a lot. So the final piece is fitting in the chemicals into that. So the chemical mediators, remember, mediate means to help, so they help this response. The most important one, if you only remember one 20 years from now, I want it to be histamine. Histamine is released from a type of basophil called a mast cell. And mast cells are special because they're oriented right around vessels. They just hang out there, kind of like a security guard hangs out around a door. They're there because they're the first line of defense. So mast cells hang around vessel walls to try to prevent things from getting into your bloodstream. But they can also be stimulated to let white blood cells out so that, again, you don't get sick. Mast cells release histamine. Mast cells can also be primed. We'll go through that in the next chapter, but they can be primed with antibody. And the antibody can bind, it's called an IgE or immunoglobulin E antibody They can bind all sorts of weird pathogens, parasitic worms, but also remember, like, histamine is what makes you have an allergic reaction to things. So they can also bind allergens. And an allergen is anything that causes a response in you that's aggravated. So it could be like cat dander or pollen. So things that aren't typically going to kill you, but your body recognizes it as a terrible pathogen. And then histamine is released. And the main thing that histamine does is encourage the loosening of the precapillary sphincters, and then it encourages the contraction of the endothelial cells of the capillary. So it stimulates actin and myosin to contract. So these cells, when they contract, they get smaller, and that makes those junctions, these spaces between cells, bigger or wider. And they're wide enough that these white blood cells can slip through the capillary wall easily without being damaged. They're the only cells that can do that. All these other red blood cells and stuff, they can't leave easily. All right, so histamine is released from mast cells. It can also be released from platelets, and you might remember that platelets are not whole cells, they're just little pieces of cells. What they do is take up things in the surrounding area and put them inside of themselves as vesicles, and they'll release them at times when they want to. So platelets can take up and release histamine, but mainly they're released from mast cells, a type of basophil. So whenever histamine is released, we get increased capillary permeability. And this is why when you have an allergy to something, so let's say you're allergic to cats and you go into a room where a cat was just like hanging out, like doing cat stuff, the cat dander will bind, histamine will be released, and now your nose might start running and you might get itchy and you're sneezing. Well, that's because these junctions are wide, you've got exudate filling up, and that's what's coming out of your nose. It's not really mucus, it's like exudate that's being forced out. Okay, so we've got histamine. The other thing that's released along with histamine, and in this case it's only the platelets that release it, is serotonin. And you might think of serotonin as something only in the brain, but serotonin is all over in the periphery. And serotonin is also a major vasodilator. So it helps make vessels more permeable too by allowing the same thing that histamine does. It allows these cells to contract and makes those spaces wider so the cells are more likely to let out fluid and then the white blood cells. The other thing that serotonin is important for is its anti-pain. So when there's a lot of serotonin released due to tissue injury, it engages the neurochemical mechanism for you to release your endogenous opioids so that you don't feel pain as much. That's one of the reasons that why getting massages feels so nice. When you get a deep tissue massage, it causes tissue deformation and then serotonin release. So you feel better because you've engaged your anti-pain mechanism. So endorphin is probably the one most people are familiar with. So if something releases your endorphins, it means that serotonin caused endorphin, which is an endogenous opioid. So just like morphine, to be released and then dampen your pain response. So serotonin's pretty cool. It's released from platelets. It's a vasodilator, and it helps engage the anti-pain response. Other things that are released. I'll go into more detail about this because I love pharmacology, but there is a big class of pro-inflammatory proteins called eicosanoids. Eicosanoids include all these things you see down here: thromboxanes, prostaglandins, leukotrienes. Okay, so very quickly, when the cell is damaged, remember, cells, their membranes, that's a great looking cell, are made up of phospholipids. And those phospholipids, when a cell dies, well, now we have to do something with those phospholipids. And if this is a dead cell, we want to, so here's some lot. Why can't I draw more than one thing at a time? So here is a cell. God bless America. Okay, here's a cell, and it's damaged now because there's like a hair in it, I guess. That's all I can draw. So now the cell is going to die, and now we have to process all of these dead phospholipids so that we can do other things with them. All right, so how do we do that? When phospholipids are broken down, this can either happen because of natural cell death, like your skin cells die and you get new ones, so now we have to process those phospholipids, or when you have actual injury to a tissue and you have inflammation. So when that cell's being broken down, those phospholipids will be processed by um, an enzyme called phospholipase. Phospholipase. So phospholipids, and then ACE means it's an enzyme. Phospholipase A2. Phospholipase A2 is the enzyme that changes these dead phospholipids from a damaged cell into a product called arachidonic acid. And arachidonic acid can be worked on by two different enzymes. The first is here, the lipoxygenase pathway. It's just an enzyme. We call it the LOX pathway. And lipoxygenase is an enzyme that processes arachidonic acid through a series of events into a pro-inflammatory protein called a leukotriene. So, in real life, what do I want you to know? LOX enzymes are really high in the respiratory tract, very high in the respiratory tract. What that means is that when people take things like leukotriene inhibitors, so leukotriene inhibitors, an example of that would be Singulair. You may have heard of that before, Singulair, and the generic name for that is montelukast sodium. Do you ever wonder, like, how you learned all this stuff? I don't even know. I know too many things. None of them seem to be really helpful to me. Okay, so Singulair, known as montelukast sodium, is a daily pill that's sold for asthma, and it's also sold for allergies. So when people have allergen-induced asthma, like I do, I'm allergic to down. And I found that out because I was sleeping on a down comforter with down pillows on a feather bed. And I thought I was dying when I was 17. I went to the emergency room and they're like, surprise, you're not dying. You are having an asthma attack. So I had to take albuterol, which is the generic name for your things like Flovent and whatever else they charge you lots of money for. But those are general beta 2 drugs. We talk about that more later. And they're drugs that encourage your airways or bronchioles and bronchi to open so that you don't have inflammation. And you don't have difficulty breathing. And we call them rescue inhalers because you're only supposed to use them when you're truly in danger. Because albuterol works on beta 2 receptors, we'll go into more detail of that later, but beta 2 receptors are in your bronchi, smooth muscle. So beta 2 is an inhibitory receptor, which means it blocks the action of a cell. And I can tell that it's inhibitory because this number here is an even number. And even numbers after receptors always mean that they're inhibitory. So they block the action of that cell. And we all know muscle's action is to contract. So when you take a drug that binds to beta 2 receptors in smooth muscle, like the bronchi, it relaxes it. But there's also beta 2 receptors on the heart. And in that case, those beta 2 receptors, they cause contraction, and they cause harder contraction. So what that means is if people take their rescue drugs, whoops, I just noticed I spelled that wrong. When they take their albuterol more than 2 times at a time, so you can take 2 puffs, you take 1 puff, and you wait 2 minutes. If you still can't breathe, you take another one, and that's as many as you can take. And you shouldn't do that more than 2 times a day. And if your patients are doing that, so taking their albuterol more than 2 times at a time and more than 2 times a day, if they're doing that more than twice a week, that means they're not being treated adequately. So we would call that actually under prescribing. So we always think of patients getting too many medications. If people are using their rescue inhaler more than this, that's uncontrolled asthma. So how can we prevent them from taking that many? Because we know it's going to help their bronchi by opening it up, but it's also going to increase their heart rate, their blood pressure, and in some rare cases, it causes cardiac arrest if there's any heart abnormality. So it can kill you. So that's pretty serious, right? So you put people on a drug that blocks LOX, it blocks leukotriene development. And if you don't have these pro-inflammatory proteins in the bronchi, well, then it's harder for them to spasm. Does that make sense? Hopefully. Okay. So leukotrienes we can block by blocking LOX. LOX is the main enzyme that's in the respiratory path. The other big enzyme that's pretty much everywhere in the body, the long name for it is cyclooxygenase. We just call it the COX pathway. And there's two different COX enzymes. There's COX-1 and COX-2. And we call COX-1 the good one, or the long name for it is constitutive. It keeps your normal balance of these things in your body. Whenever you see these guys, prostaglandins, they're pro-inflammatory protein, and they're shortened as PGEs. Prostaglandins, they're pro-inflammatory, so pro-inflam, and they're also highly acidic. And there's one place in your body where you actually want a highly acidic environment, and the place for that is your stomach lining. So prostaglandins, in general, whenever you find something inflamed, so if you were to take a sample from an arthritic joint, for example, you'd see a high amount of prostaglandins. Prostaglandins, pro-inflammatory, they're vasodilatory, so they help increase the permeability of vessels. So generally we don't like them, but what we do like is having a nice strong mucosal barrier. So to differentiate that, COX-1 is the enzyme that turns arachidonic acid into prostaglandins and thromboxanes, which we shorten as TXA2. And thromboxanes are the chemical signals that platelets use to call other platelets to the scene so that they can have a platelet party and make a plug, which is good in inflammation because we want to heal whatever the wound was, right? We don't want that around anymore. So COX-1, that helps maintain the mucosal barrier of the stomach, and it also helps maintain our platelet binding. COX-2 is the enzyme that is only activated when there's tissue damage. So in our example where somebody has cellular damage, there's a splinter, a paper cut, that's when the COX-2 enzyme is activated. So the COX-1 enzyme we like, it does good things for our body. COX-2 we don't like. It still is going to lead to the production of thromboxanes and prostaglandins, but it's only in the case of inflammation. So here's where the drugs fit in here. So we said things like leukotriene inhibitors like Singulair, they block lipoxygenase so that we don't get leukotrienes, and that's mainly important in the respiratory tract. Cyclooxygenase can be blocked from turning arachidonic acid into these pro-inflammatory prostaglandins and thromboxanes by the big class of drugs called non-steroidal anti-inflammatory drugs. So those include three different, well, lots of different ones, but the three most common are aspirin, ibuprofen, and naproxen sodium, which is sold as Aleve. So ibuprofen is sold as like Motrin. What else is it sold as? Excedrin, a whole bunch of things. It's usually brown in color or orange. Naproxen sodium is sold as Aleve. Aspirin is sold as aspirin. It's sold by Bayer, but it's marketed by lots of other companies as well. They all do the same thing. They block COX-1 and COX-2. Why is that important? Ideally, we would just block the bad enzyme, right? That's the one that's around. It causes inflammation and damage, and maybe we could block that and block, like arthritis. Instead, NSAIDs, they block COX-1 and 2, meaning when people take aspirin every day, they're typically doing that to block thromboxane so that their platelets are less likely to bind together and form clots. That's going to lower their risk of stroke and heart attack, and that's good. But it's also going to block COX-1 activity, which maintains the mucosal stomach barrier. That's why you'll see people get ulcers and things of that nature when they're taking NSAIDs on a daily basis. It's breaking down, or it's blocking COX-1 and COX-2. So you might think like, well, hey, why don't we make a drug that just blocks this bad one, just blocks COX-2? Well, we did that, and you can spot these drugs. They always end in coxib, so rofexicoxib, and there is celecoxib. Rofexicoxib was sold as Vioxx, and celecoxib is still on the market. It's sold as Celebrex, and their commercials are the people singing like, celebrate, celebrate, do what you want to do. That was really fun to sing. Vioxx was voluntarily pulled from the market by Merck. Before Vioxx went on the market and started killing people, wow, fun, they thought COX-2 would have no effect on thromboxane. Everyone always thought that was only COX-1 that affected thromboxane. Turns out when you block COX-2, you shift the amount of thromboxane in the body, and people taking Vioxx, they were having increased strokes and heart attacks, which is not good. So Merck voluntarily pulled it from the market and just put out a statement like, sorry, we don't sell this anymore. And that was it. Celebrex is still on the market, and it carries a black box warning, which says may increase risk of stroke or heart attack. So be careful when you take this. And if you think about what kind of patients would have a really low stroke risk who you would feel comfortable using Celebrex with, a good example are like adolescents. So let's say, I've missed some letters in there, whatever, adolescents. You have a 12-year-old who got a knee injury in football or soccer, and their knee hurts really bad, and you need to do something about it so they can walk. Well, you don't want to give them aspirin because that's bad for kids. You don't want to necessarily like pump them full of enough ibuprofen to get rid of the pain. So celecoxib is a way to block COX-2, make their joint pain less, and we know that they're not going to have a stroke. Like a 12-year-old stroke risk is very, very, very minimal. And you'd also choose this if a patient has a history of stomach ulcers, because if we do a cost-benefit analysis, it's better that we know they're not going to have an ulcer again and start bleeding. Okay, hope that makes sense. I'm happy to talk through this with you. The final thing that I just want to mention is the strongest anti-inflammatory substance are steroids. So that's anything that ends in zone. So prednisone, cortisone. And the reason why those things are so strong are because they block phospholipase A2. That's what steroids do. That steroids also break down your connective tissue. They make diabetes worse. They make glaucoma worse, cataracts worse. So you can't give them to everybody all the time, but they are very, very potent because they block phospholipase A2. So the phospholipids never turn into arachidonic acid, and then arachidonic acid can't be turned into any of these pro-inflammatory proteins. Whew, okay, our native ones that we make in our body are called cortico, which means cortex. They're made by the adrenal cortex. And steroid means it has a steroid backbone made out of cholesterol, corticosteroids. So they prevent phospholipase A2. NSAIDs block cyclooxygenase 1 and 2, and lipoxygenase pathways can be blocked with these LOX inhibitors, but LOX is primarily in the respiratory system, where the COX enzyme is all over the body. Hooray, anti-inflammatory drugs. Just a couple things left to go, and then we're done with this one. Final thing, we talk about this a lot in the course. One of the things your body does naturally to try to prevent shear stress or vessel walls being damaged by things brushing against them or scraping against them, cells can make their own nitric oxide. And they do so by forming a complex called L-arginine, and then they make it into nitric oxide, which is a gas. And nitric oxide, because it's a gas, diffuses really readily, and it causes vasodilation. So that's something naturally made by the body. And as long as vessels are compliant, meaning they're not stiff, they don't have high resistance, and vessels can get big and then small again, nitric oxide works really well, made natively by the body. The first sign that vessels are losing their compliance, like in atherosclerosis, in males is erectile dysfunction, because in order for an erection to occur, you have to have compliant vessels making nitric oxide to relax the vessels in the corpus cavernosum penile region. In that case, people take a drug you've probably heard of called Viagra. And what Viagra does, it's a nitric oxide donor, so that it allows vessels to be compliant so that males can achieve and maintain an erection. In the stroke or in the shock chapter, we'll talk about why, well, I'll say it really quickly now. The reason why in Viagra commercials it says at the end, like, ask your doctor if you're healthy enough for sexual activity. Usually people laugh, but it's not that funny, because think about what people take when they get chest pain. They take what? Nitroglycerin. They put it underneath their tongue, which is nitric oxide. So let's say somebody got their prescription for Viagra, and they're like, great, it's going to be a wonderful night. I'm going to pop my pill. And then they start engaging in sexual activity, and their heart starts to hurt. They have a heart failure in some way. They're taking aspirin, and they have a prescription for nitroglycerin. So they might have a blockage or something. So their chest pain occurs, so they've already taken Viagra, which is a nitric oxide donor, and then their chest pain occurs, so they take their nitroglycerin. So now they have nitro on nitro. You have so much vasodilation in that case that it actually leads to shock. It's called pharmacologic induced shock. So maybe that will help you remember that nitric oxide is made by cells from L-arginine so that there's vasodilation. So very, very potent vasodilator. Okay, final thing, the plasma-derived mediators. You will also see these in the short video that I will post for you. The first is bradykinin. Bradykinin is formed in the kinin cascade, and bradykinin is what stimulates your pain receptors, and that makes things hurt. So bradykinin is important in letting something hurt so that you're less likely to use it and then get it injured further. Then there's complement. Complement is a cascade that's activated. We'll talk about this more in the next chapter, but the complement cascade is like 25 steps, but the end of it is a cylindrical complex that is inserted into a cell wall. So if the body recognizes this cell as damaged or diseased or carrying a pathogen, complement can be activated. We put together this nice little circle, then we punch it into a cell, and a cell obviously can't live with a big cylindrical complex in it. If I punched into your abdomen a cylinder the size of, I don't know, like a pipe, you're not going to live that way. You're going to bleed and then probably die. That's what happens to these cells. So they just swell, they burst, and now we don't have a pathogen living in the cell anymore. So we call that lysis. Lysis means to break apart. Complement also encourages histamine release. It aids in chemotaxis, because wherever there's complement, white blood cells and macrophages are attracted to that area. And if they're there, that means they can phagocytize things. And then the final thing is fibrin, the clotting system. So the body, if everything goes properly, removes the pathogen, but we also have to seal the wound. We have to make a clot. so that we don't lose blood. So the clotting system through the coagulation cascade is activated too. And we call these the plasma-derived mediators because the pieces for these are in the plasma. They're only assembled when we need them. And you can imagine why that's important. We don't want fibrin making scar tissue, or we don't want scar tissue just going around in our bloodstream. We'd have scar tissue everywhere. So we only put these together when inflammation encourages them to act. Oh my goodness, that was a lot of talking. I'm going to go take a nap underneath my desk, and that's it. That's the end of what I'm going to do. So here's your summary slide, everything that we went through. So bacteria enters in the case of injury. We want to get rid of all this, garbage. We want to take out the trash, so we need to let those white blood cells out. So platelets are going to come and start sealing up this area, and then we're going to have the first part of the inflammatory response happen where the mast cell releases histamine, causes these endothelial cells to contract. We have increased vessel permeability, letting the white blood cells out, so they engage in margination, tethering, rolling, activation, adhesion, migration or diapedesis. Chemotaxis is used to move to the site of injury, and then phagocytosis and destruction. And then we have other mononuclear cells come afterwards, and then we are going to seal up this wound and engage in healing. Okay, so in the next lecture, I will go through the clinical signs of inflammation, but you have more than enough to think about and do now. All right, let me know if you have any questions. Thanks. Bye.